Cardiology Grand Round. Welcome to Cardiology Grand Rounds. It's my pleasure and an honor to introduce our distinguished speaker today, Dr. Howard Eisen. Dr. Eisen is a professor of medicine and medical director of cardiac transplant, mechanical circulatory support, and advanced heart failure programs at Hershey Medical Center, Penn State University College of Medicine, and former chief of cardiology division at Hahnemann University Hospital, Drexel University College of Medicine. He is the Joseph De Palma Family Professor of Cardiology and Thomas Wisher Professor of Medicine at Drexel University College of Medicine. He is an icon in the field of heart transplant, and he's known as Guru of Immunosuppression. I'm not sure if Dr. Eisen, you know this or not. That's what we used to call you behind your back, a Guru of Immunosuppression.
I guess there are a lot worse things you could have called me.
So he actually led the largest heart transplant program in the country when he was at Temple, and he was instrumental in running numerous clinical trials with immunosuppressive regimens. He led the everolimus versus MMF clinical trial, the largest immunosuppressive clinical trial in cardiac transplant, and a pioneer in the field. And I have had the honor of working with him. I was his intern, resident, fellow. So the term that we call for people who are trained by Dr. Eisen, Eisenet. So being an Eisenet, it's a distinguished pleasure for me to introduce Dr. Eisen. And here we are. And who better can talk to us about the journey of heart transplant over 50 years, a story of success from azathioprine to mTOR inhibitors. Thank you, Dr. Eisen.
Thank you, Marula, for that very generous and kind introduction. One would think that after all that time training with me, you might be kind of tired of hanging out. But it's an honor to do this. It would be, of course, much nicer to do it in person, but maybe that day will come. Let me see if I can share my slides.
Can you share screen, Dr. Eisen?
Yeah, I'm trying to. It's doesn't seem to be letting me do that.
Is it giving an error or just not letting you select it?
Yeah, it's not letting me do it, so that's strange.
You can try now.
Let me try again, yeah. Okay. Yeah, it's not letting me do it. Boy, that's
Dr. Eisen, do you want to log off and log back in? Maybe that might work.
yeah, let me do that. Sorry about that. The camera doesn't work, but we got the slides, so we'll go ahead with that. Thank you for the invitation. I'm going to go through the history of heart transplantation. This talk was originally given, been updated, but it was originally given in December 2017 at a symposium in Cape Town, South Africa, to commemorate the 50th anniversary of the first heart transplant. And I have nothing financially to disclose. I will be talking about the off-label use of everolimus, which is for heart transplant, which is approved by the FDA for renal and liver transplant, and outside the US for cardiac transplant. And then sirolimus, which is approved by the FDA for renal transplant. So these are the talk objectives, including understanding how cardiac transplantation has developed, be able to identify current immunosuppressive therapy for heart transplant recipients, as well as their rationale, and become knowledgeable about the biomarkers that we use to detect rejection in cardiac allograft vasculopathy. So this is when it started, December 3rd, 1967. I remember this pretty well. I was in elementary school at the time. It's been 54 years and more than 150,000 transplants. First transplant was done by Christian Barnard. He was a South African surgeon who trained in cardiothoracic surgery at the University of Minnesota. He set up the first cardiac surgery program in South Africa at Groote Schuur Hospital in Cape Town. And he had observed Norman Shumway at Stanford perform heart transplants in animals. So he performed animal heart and kidney transplants in the 60s. And the first heart transplant in humans, December 3rd, 1967. One of his patients, actually, transplant 69, lived 24 years. But he performed 48 orthotopic and 10 heterotopic transplants before the program was shut down due to poor outcomes, and that happened around the world. This is Groote Schuur Hospital, and over here is the Heart Transplant Museum. And Groote Schuur means, in Afrikaans, means big barn. But over the years, I'd heard about this heart transplant museum from our patients who would go down to Cape Town to visit it. This is Christian Barnard with, on the left, Gina Lollobrigida, famous Italian actress. On the right, Golda Meir, the Israeli prime minister. And he basically went around the world, and it was a sensation. The first heart transplant was Louis Wiskansky, who was in his 50s, what would now be a very common phenotype, ischemic cardiomyopathy, diabetes. The donor heart came from a woman named Denise Dorval, who was killed in an auto accident. She wasn't brain dead because at that time, there was no definition of brain death. There was no real good way to detect brainstem function. So she was really the first donor after cardiac death, which is something that's now become more common in the UK, Australia, and in the US. He underwent transplant on December 3rd, 1967, died 18 days later from pneumonia, likely from immunosuppression. He had these pulmonary infiltrates, and the physicians, not knowing what rejection looked like clinically, treated him for rejection, giving him steroids, high doses, and antibodies, and he died. The second transplant was done in a few weeks later in Brooklyn at Maimonides Hospital in a child. That transplant also lasted only a few weeks. But the woman who was the transplant coordinator for that second transplant, many years later would be the wife of one of our heart transplant patients at Drexel Hahnemann. So she was the first transplant coordinator. The second South African and third heart transplant was Philip Blayberg, 59-year-old dentist. I don't know what it was about South African dentists, but the first two transplants were dentists. Also ischemic cardiomyopathy, multiple MIs, received a multiracial donor, and he survived 19 months and 15 days succumbing to transplant coronary disease. Cardiac allograft vasculopathy. He's the first person known to have developed this disease. So the next few years were difficult. This sign is from, as you went to the Cornell University campus, which is where I went to college, and that accurately describes the 4 years of Cornell. Anyway, there was a rough road ahead. This is early immunosuppression, azathioprine, a failed leukemia drug, steroids, and anti-lymphocyte antibodies, basically anything that they could grab a hold of. Azathioprine. By 1971, things had turned bad. This is an article about Texas Heart, and all 6 of these people died after transplant. This was given to me by one of my patients. I don't know if she's trying to send me a message, but if you read the article, cardiologists at the Texas Heart Institute were barricading the doors to the ORs to prevent transplants because the outcomes were so poor. People were dying mainly of infection. So what happened? Well, this is the how the immune system responds to transplanted organs. You can see it's very complicated with 3 different signals. This is the one we block with cyclosporin. This is the one we block with some of the anti-proliferatives we use, or everolimus or sirolimus. And these are some of the ones we block with antibodies. But none of this was known in 1967. And it became known in 1974 when these two gentlemen, Peter Doherty from Australia and Ralph Zinkernagel from Switzerland, identified the way that the immune system recognizes foreign proteins, including those on transplanted organs. And they received in 1996 the Nobel Prize for their discoveries. So that, and this is basically what happens. There's two ways to recognize foreign organs. One is the direct pathway, which is the classic pathway, where a fragment of an HLA antigen from the donor organ is presented by these cells, the allogeneic APC cells, to T cells, CD4 and CD8, and they proliferate, produce cytokines, stimulate B cells, and then they assault the organ. Another way, which is novel for organ transplantation, is where the antigen presenting cell just directly recognizes the helper cell, directly recognizes the foreign antigens, and that also results in activation of T cells. And so one gets a cascade of T cell proliferation, activation, B cell activation, proliferation, and production of antibodies, all of which can destroy the transplanted organ. So the primary goal of immunosuppression is to blunt this response to prevent destruction from the of the transplanted organ. And allograft cells are distinguished from recipient cells by MHC, major histocompatibility, class 1 and class 2 antigens. And as a result of all this information, expression of MHC antigens is actually enhanced so that the transplanted organ becomes more of a target. This is Norman Shumway, who really developed this field to the point where it became successful. So after all of the other programs in the world just about shut down heart transplant programs as a result of bad outcomes, including the one in Cape Town, he persevered. He was at Stanford. His first transplant was in January 1968. He developed the surgical technique in dogs. This was the first transplant at Stanford, 56-year-old with myocarditis. And this gentleman lived 14 days. His heart was functioning well. He developed hepatic failure. But he persevered, did the first heart-lung transplant in 1981. And what really made things take off was the development of cyclosporin, which was the first relatively specific immunosuppressive agent. They were the first heart center to use this and show that it improved survivals. And over 1,300 heart transplants have been performed at Stanford since then. This is the 50th anniversary commemoration of their first heart transplant. And this is cyclosporin. See, it's cyclical. It was derived from fungi. And what it does is it blocks a transcription factor that stimulates the production of the cytokine interleukin-2, which activates T cells, makes them angry, and increases proliferation. And this shows the result of after the early cyclosporin studies that showed that while rejection was as common as it was before cyclosporin, it was no longer a death sentence, and people did well, and they had better, they didn't die of rejection. The number of transplants went up dramatically, as did the number of transplant centers. And this is where cyclosporin works. It inhibits calcineurin. Calcineurin inhibitor blocks this transcription factor, which in turn produces interleukin-2, which stimulates the T cells. So this reduces T cell proliferation and activation. And there's another calcineurin inhibitor, tacrolimus, which has been felt to be more effective and is now the predominant one we use. One seminal development was in 1995 when Kobayashi and the group at UCLA did a randomized study of pravastatin versus controls and showed there was an improvement in survival, reduction in cardiac allograft vasculopathy, less rejection. And this really was kind of iconoclastic because before this, the the dogma was that you can't use statins in heart transplant patients because they show that they result in severe rhabdomyolysis. This was repeated by a German group using simvastatin, another randomized trial, similar results. So the use of statins in the early post-transplant period has become standard of care. It's a class 1 recommendation in the ISHLT guidelines, and it's regardless of the cholesterol levels. And this is 10-year data from the UCLA group showing improved survival in the pravastatin group and greater freedom from cardiac allograft vasculopathy or death. So the first big clinical trial, up until this point, azathioprine was the main anti-proliferative. So the immunosuppression at the time was moderate doses of cyclosporin, azathioprine, and prednisone. Initially, when cyclosporin was used, it was used in high doses, which result in malignancy and renal failure. So the triple therapy, which has become the standard of care that we use now, was introduced in the mid-'80s. And so a randomized trial comparing mycophenolate mofetil, another anti-proliferative, to azathioprine was conducted. And this showed reduction in mortality, reduction in rejection with hemodynamic compromise, and reduction in rejection, recalcitrant rejection requiring cytolytic therapy. So as a result of this study, mycophenolate mofetil or CellCept completely replaced azathioprine. There was an effort to see if there was an effect on cardiac allograft vasculopathy. Quantitative angiography was done, intravascular ultrasound was done, and there really was no significant difference. The diagnosis of cardiac allograft vasculopathy has, since the early 1970s, been done by endomyocardial biopsy, which is where several pieces of tissue are obtained starting 1 week post-transplant, and most frequently in the first few months. And the tissue, this shows how it's done, and the tissue is examined by a pathologist, where the severity of rejection is graded based on the extent of T-cell infiltration and myocyte necrosis. And these categories, this was revised in 2005, these categories are where we treat. And this shows what we're talking about, grade 1A, or these are mild, some lymphocytes around blood vessel, a few lymphocytes scattered, more lymphocytes, but no myocyte necrosis. This is where we treat. This would be a grade 2R here, where there's myocyte necrosis, more extensive lymphocyte infiltration than here, inflammatory infiltrates. So the standard of care at this point is calcineurin inhibitors, cyclosporin, and tacrolimus, which inhibit T-cell proliferation, activation via calcineurin and IL-2 expression. Mycophenolate mofetil, which inhibits purine synthesis, T-cell proliferation, and corticosteroids, which do all sorts of things. They inhibit cytokine elaboration, lymphocyte circulation, and T-cell proliferation. And this kind of shows, again, the mechanism of action of immunosuppressive drugs. And this is how corticosteroids work. The reason why tacrolimus became the standard of care and replaced cyclosporin largely is this clinical trial that was done about 15 years ago. Was called the 3-arm study because there are 3 arms. The patients are randomized to tacrolimus and sirolimus versus tacrolimus MMF versus cyclosporin and MMF. And what was found was that the tacrolimus MMF arm had the lowest rate of rejection and an optimal survival. So that replaced cyclosporin, more effective in preventing rejection. But one thing that was seen was that cardiac allograft vasculopathy was still the major cause of death in these patients, and that the immunosuppressive drugs that we were using were not terribly effective at stopping that. So the mammalian target of rapamycin drugs are inhibitors of T-cell proliferation, but also proliferation of other cells, such as vascular smooth muscle cells, which proliferate and respond to endothelial injury. For example, after transplant as a result of ischemia reperfusion from the transplant procedure and as a result of the immune assault against the allograft. And so this shows sirolimus, which binds to the FK binding protein and inhibits this protein called target of rapamycin. Rapamycin is the other name for sirolimus. And mTOR, mammalian target of rapamycin, is critical in cell proliferation. So these drugs have been used in another form of vascular smooth muscle cell proliferation in response to injury. They're used in drug-eluting stents. So 20 years ago, there was a clinical trial reported in the New England Journal of Medicine from Europe, the Revel trial, where patients were randomized to bare metal stents or sirolimus-eluting stents. The restenosis rate was 0 in the sirolimus-eluting stents and 26% in the bare metal stents. And survival, event-free survival, was dramatically better in the sirolimus-eluting stents. Now, how did this work? Well, when you deploy a stent, you injure the endothelium. That results in an injury response, which is smooth muscle cell proliferation. Yet, with the direct administration of sirolimus and antiproliferative, that inhibits the smooth muscle cell proliferation. And just to show that this works in the United States, another clinical trial a few weeks later, the Sirius trial, found the same results, randomized trial of bare metal stents to sirolimus-eluting stents. So in order to get this to work in heart transplant patients, you have to give it systemically. So there were 2 big clinical trials almost 20 years ago. One was the sirolimus randomized trial in heart transplant patients done in Australia and New Zealand. And so they randomized 136 patients to either receive 1 of 2 doses of sirolimus or azathioprine. And the endpoint was rejection rate, but they also looked at severity of cardiac allograft vasculopathy using intravascular ultrasound. Now you're probably saying, okay, why did they compare it to azathioprine? And the reason is that at that point, in the early 2000s, MMF was not approved in most countries. And so azathioprine was still the standard of care as an antiproliferative. So the rejection rate was reduced with sirolimus. There was more herpes. There was a higher serum creatinine. This is an important thing to note. And based on IVUS, which they did, they compared IVUS progression from baseline to 6 months later. There was greater progression of cardiac allograft vasculopathy, looking at a variety of different parameters, IVUS parameters in the azathioprine group in red compared to the sirolimus group in green. So sirolimus immunosuppression reduced the 6-month rate of acute rejection, creatinine was higher, and progression of cardiac allograft vasculopathy was significantly reduced. The rest of the world did what was called the RAD trial, which is using a different mTOR inhibitor, everolimus, in heart transplant patients. This was done in North America, in South America, Europe, and Asia. And there was a composite endpoint. RAD is everolimus, 2 doses of everolimus, a composite endpoint of rejection at 6 months, proved by biopsy, greater than at that's called 3A, now called 2R, rejection with hemodynamic compromise, graft loss, death, or loss to follow-up. And so fewer patients reached this endpoint in the everolimus groups compared to azathioprine. And this was driven entirely by a reduction in grade 2R rejections. There was also an IVUS sub-study in this clinical trial where patients received IVUS at baseline and at 12 months, the thought being this drug could mitigate cardiac allograft vasculopathy. And a number of parameters we used to study this. The major one is maximal intimal thickness, change in maximal intimal thickness from baseline to 1 year. The reason why this was of interest to us was that there had already been some studies showing that the change in maximal intimal thickness from baseline to 1 year was predictive of major adverse cardiac events, heart failure, and death in these patients 5 years post-transplant. So there was less progression of cardiac allograft vasculopathy defined by change in maximal intimal thickness in the 2 everolimus groups compared to the azathioprine group. And other measures, volumetric measures, were also attenuated by everolimus. We also assessed the incidence of cardiac allograft vasculopathy, which is defined as a change in maximal intimal thickness from baseline to greater than 0.5 millimeters from baseline to 1 year later. This would show somebody who has cardiac allograft vasculopathy. And the incidence was significantly reduced in the everolimus groups compared to the azathioprine groups. But there were storm clouds on the horizon. The patients with receiving everolimus had lower creatinine clearances and higher serum creatinines. And this observation was presented to me by one of our brand new transplant coordinators, one of these, the emperor has no clothes kind of things, where she said, I've been looking at these patients in this clinical trial, and a lot of them have higher creatinines and lower creatinine clearances. And being a open-minded clinical investigator, I said, that can't be, but she had an Excel spreadsheet which documented it. And sure enough, this was something that that was occurring in the patients, some of the patients in the clinical trial. And their cyclosporin levels were not higher than in the people who weren't in the trial. So it appeared to be independent of cyclosporin. Cyclosporin tacrolimus have nephrotoxicity as a major side effect. So we reported to the sponsor that this was going on, and they queried the other sites, and sure enough, they were seeing it as well. So the plan, what we did was we reduced the target cyclosporin trough, and that was based on this data from the study, which showed that independent of your cyclosporin level, beyond 2 weeks post-transplant, if you had a therapeutic everolimus level, your rejection rates were the same. So you could reduce cyclosporin if you had a therapeutic everolimus level and not have increase the risk of rejection. So the bottom line was that there was less cardiac allograft vasculopathy with everolimus compared to azathioprine. There were higher serum creatinine levels and less rejection. So another study was done to compare everolimus to mycophenolate, which now had been approved around the world and was the major anti-proliferative agent. And also the goal was to see whether patients could be managed with lower cyclosporin trough levels. So we didn't get cardiac allograft didn't get renal insufficiency. So this is the clinical trial. This was the largest clinical trial ever done in heart transplant patients. Similar primary endpoint to the first trial, and a safety objective comparing renal function determined by GFR. This is where the study was done. So it was done in every continent except Africa and Antarctica. And this is the protocol. So patients receiving everolimus had much lower target trough levels early on compared to the mycophenolate group, which had standard cyclosporin trough levels. The high-dose everolimus group was stopped by the Data Safety Monitoring Board because there was an excess of deaths, although the survival rate at 1 year in this group was 90%, but it was higher than in the other two groups. And this shows some of the complications. One concern that was seen when, after the first clinical trials, some centers decided to use sirolimus independently and found that there were problems with wound dehiscence when it was used in de novo patients, and also mediastinal mediastinitis. And that was not seen in this study. What was seen was increased pericardial effusions in patients getting everolimus. So the recommendation was that patients, of course, get echocardiograms, which they get anyway. And in terms of the difference between rejections, there was also an IVUS stub study for this study. There was no difference in terms of rejections. And in those patients who had reduced cyclosporin trough levels, there was no increase in creatinine or decrease in GFR. And when one compares the IVUS results, everolimus compared to MMF, there was a much lower incidence of cardiac allograft vasculopathy, less progression of cardiac allograft vasculopathy defined by IVUS maximal intimal thickness change And also, if one looked at volumetric measures across the board, everolimus was superior to mycophenolate mofetil. And if one looked at subgroups, including groups that were more likely to develop cardiac allograft vasculopathy, older patients, males, patients with diabetes, patients with donor disease, everolimus was superior to mycophenolate mofetil. So I think in summary, cardiac allograft vasculopathy could be attenuated using everolimus compared to mycophenolate mofetil. No difference in rejections, and if you reduce the cyclosporin trough levels, you don't get the renal insufficiency that was seen in the first study. The increased death rate in the higher dose was due to what was called a country effect. So you may have heard of a center effect, where the outcomes are so bad in the clinical trial in one center that they distort the overall survival rate. And in the study, we had a center effect. There was a country effect, rather. We had one country that had very poor post-transplant outcomes, and that country will remain unidentified, but it's in Europe. It's between France and Poland, Switzerland and Denmark. You can look at a map and see which one it was. They had a 64% one-year survival for patients not in the clinical trial. So we were unaware of this. They were having lots of problems with the transplant programs back then. So in summary, there was no difference in terms of incidence of wound complications statistically, and there were greater frequency of pericardial effusions, no tamponades, and so the recommendation was frequent echocardiography, but less cardiac allograft vasculopathy. So our conclusion was that using these drugs de novo can be very complicated. So other groups have looked at using this several weeks, months, or even a year post-transplant. This is the schedule study from Scandinavia, where they had two arms. One was an arm that got standard therapy. The other was an arm that at week 7 to 11, patients had cyclosporin withdrawn, everolimus was added. And what they found was that there was less progression of cardiac allograft vasculopathy by IVUS. And they also found, as defined by change in maximal thickness and also volumetric measures, they found lower incidence of cardiac allograft vasculopathy. And this was, and in multivariate analysis, the strongest predictor of attenuation of cardiac allograft vasculopathy is treatment with everolimus. So there was a higher rejection rate in patients receiving everolimus, but there was no hemodynamic compromise or mortality associated with this. And there were a few patients who had frequent, i.e. 2 or more 2R rejections within the first 6 months. So they actually had cyclosporin added to their regimen. And one thing that's been observed in all of the mTOR studies has been that there's less cytomegalovirus infection. Cytomegalovirus is a common opportunistic infection that can cause neutropenia, can cause pneumonitis, retinitis, colitis, can be very unpleasant. But there was less in the mTOR inhibitor patients treated with compared to those not treated with mTORs. And then another study from the Mayo Clinic involved conversion of patients at 1 year to getting cyclosporin, as opposed to, so switching from cyclosporin to sirolimus versus patients not switched. And what they found is if you do this later, you're less likely to get benefits. So if you do it by a year, you're more likely to get benefit in terms of cardiac allograft vasculopathy. What they did IVUS, which showed less progression of patients receiving sirolimus versus calcineurin inhibitors. And this is shown here as well, and here as well. And perhaps the most salient point and exciting point of the study was that there was a lower incidence of all-cause mortality in the patients receiving sirolimus compared to cyclosporin, lower incidence of cardiac death, and lower incidence of cardiac allograft vasculopathy related events. So what this means is you can get the benefit of using these drugs without all the complications of using them de novo. And this is the instance of cardiac allograft related events or death. This is early conversion, around 1 year. Later conversion, this is no conversion. So mTOR inhibitors when started later after transplant can attenuate the development of cardiac allograft vasculopathy, favorably influencing outcomes such as MACE and death. And these strategies can mitigate the issues of renal dysfunction and wound healing seen when these agents are used in de novo transplant patients. Now we have lots of people with established cardiac allograft vasculopathy, and what do we do for them? There've been a few small studies looking at this. This is from Donna Mancini when she was at Columbia. She randomized patients either to get sirolimus or stay on their standard therapies and looked at something called the catheterization score and showed that there was no progression of cardiac allograft vasculopathy based on catheterization results. This is in control, and this is sirolimus group. And they also looked at the composite of catheterization score, death, acute MI, need for intervention. And again, there was greater freedom in the sirolimus group versus the control group. The Spanish group looked at converting people to everolimus. They looked at clinical outcomes, very small study. So there really weren't any differences. They had an IVUS sub-study. And they actually were able to significantly reduce cyclosporin levels in their patients. There was no difference in terms of clinical events. Study was small, but in terms of progression of cardiac allograft vasculopathy, that was attenuated in the everolimus group compared to the standard group. Also, in terms of other measurements, the same was observed. So nowadays, in the absence of a large clinical trial, we will routinely start these drugs in people with established cardiac allograft vasculopathy. They also are, if they have lesions amenable to percutaneous intervention, they will get that as well. So this is the conclusion of using mTOR inhibitors, also known as proliferation signal inhibitors. So not everything works on cardiac allograft vasculopathy. This is a more recent clinical trial funded by the NIH using rituximab, which is an anti-CD20 monoclonal antibody, and it inhibits B cells, which produce antibodies. The rationale was that we know that presence of antibodies against the transplanted organ are associated with development of cardiac allograft vasculopathy. If we can block this, we should be able to reduce the likelihood of cardiac allograft vasculopathy. So it was a multi-center study. Patients were randomized to receive either 4 doses of rituximab versus placebo within the first 8 weeks post-transplant. IVUS was obtained at baseline and 12 months to assess progression of cardiac allograft vasculopathy. This is the study. And here's a surprise. Patients who received placebo were less likely to have progression of cardiac allograft vasculopathy compared to rituximab. And as to why this happens is not entirely clear, but it's thought that rituximab may also have a stimulatory effect on B cells and may produce B cell responses that result in cardiac allograft vasculopathy. And I think this points out the complexity of the immune response, so that just because we think something may happen, it doesn't happen. So here's additional good news. Over time, the survival post-transplant has improved significantly, but most of that's in the first 6 months, and most of that's due to reduced frequency of rejection, fewer infections, better ICU care. And if you notice, beyond the first year post-transplant, the slopes are the same. So there are things that are killing our patients, and those things include cardiac allograft vasculopathy and malignancy. Cardiac allograft vasculopathy, there's greater freedom now than there was 20 years ago, probably due in part to the widespread use of statins. There's less renal dysfunction, and that's because we are more likely to reduce calcineurin inhibitors to maintain creatinines less than 2 and 1 year post-transplant. And there's less malignancy. That may be due to the overall reduction of immunosuppression. We wean our people off steroids within the first 6 months. This shows the functional status of patients post-transplant, so it is overall excellent. And the employment status. This is the evolution of public perception. So from the gift of a human heart to a tragic record of heart transplant to an exceptional view of life, transplant has been redeemed as a result of improvements in immunosuppression as a result of greater understanding of the immune system and advances in science. And here we have Newsweek, how transplant saves lives. Malignancy, as I mentioned, is another major cause of death post-transplant, right behind cardiac allograft vasculopathy. The major forms of malignancy that we see in patients are squamous cell carcinomas of the skin, and that's because a lot of these patients are fair-skinned and were exposed to sunlight when they were growing up without sunscreen, which we, as I recall as a kid, we didn't really have. And then this all catches up to people. And then there's some unique malignancies, lymphoma, in particular post-transplant lymphoproliferative disease, which is associated with Epstein-Barr virus infections, can also cause death. And there are 2 forms of that disease. One is a polyclonal form, which is directly associated with EBV and responds to weaning of immunosuppression and can basically completely resolve. Beyond the first year, there's a monoclonal version that is much more aggressive and much more akin to lymphoma that we see in non-transplant patients. And adenocarcinomas are not more likely to occur in these patients, but if they do occur, they are much more aggressive. So as part of the pre-transplant evaluation, we will do colonoscopies, mammography, we'll do PSAs, and in patients who are smokers, we'll do CT scans to see if we can identify the presence of incipient adenocarcinomas. This is the immunosuppression used nowadays. You can see tacrolimus has replaced cyclosporin, MMF has replaced azathioprine, and the mTOR inhibitors have had a slow uptake. And this is the immunosuppression at the time of follow-up. And so when patients have malignancies, not surprisingly, their survival is dramatically reduced. There are some issues in terms of understanding malignancy. We think that certain immunosuppressive agents are more likely to result in malignancy than others. Azathioprine, some of the early antibodies that were used, and the amount of immunosuppression is also associated with cancer risk. So an area of considerable interest is the efficacy of low or minimal immunosuppressive regimens to reduce the cancer risk. And then the frequency of cancer screening and components of the cancer screening. We use the American Cancer Society recommendations, but it may need to be more frequent than that in particular patients. And here's mTOR again, which is involved not just in proliferation of lymphocytes and smooth muscle cells, but also in proliferation of cancer cells. And so there's some evidence that they may attenuate malignancies. This was from the renal transplant database, the SRTR, which showed that patients who received either mTOR inhibitors alone or mTOR inhibitors and calcineurin inhibitors were significantly less likely to develop malignancies compared to patients on calcineurin inhibitors alone. So there is a signal here, and this has been studied in clinical trials. While we were doing our everolimus heart transplant study, there was a study in patients with breast cancer, metastatic breast cancer, who had progression on endocrine therapy, Bolero-2. They used very high doses of everolimus versus placebo and showed less rejection in the everolimus versus the placebo group. So these drugs are now approved as adjunctive therapy in breast cancer and renal cell carcinoma, and they're being evaluated in others. Now let's turn to monitoring and rejection again. There's been kind of a revolution in that as well. We in managing these patients, we follow like a balancing act between either over-immunosuppression resulting in cancer, drug toxicity or infections, or under-immunosuppression resulting in rejection. And so there's been a real interest in developing a screening test for rejection, highly sensitive for rejection, adverse outcomes. Negative test strongly associated with good prognosis. Positive test indicates need for treatment, further workup. Non-invasive, can be done frequently, low complication rate, and decreased costs. And so we focused on changes in gene expression in the peripheral blood lymphocytes, many of which are helper T cells, cytotoxic T cells, and are involved in rejection. And that's these cells here. So that led to the CARGO, cardiac allograft rejection gene observation clinical study, in which 4-year observational study in 8 centers in the early 2000s, where we identified genes whose expression changed in peripheral blood as a result of grade 2R or 3 rejection compared to no rejection. And we initially looked at the changes in gene expression. This is called a heat map. And so these genes have increased expression, these have decreased expression. And so a number of different genes whose expression changed were put into a panel that could assess changes in gene expression. And we looked at a number of different genes from a variety of different pathways. And this resulted in a test now known as the AlloMap, which can distinguish grade 2R rejection from grade 0 rejection, has a very high negative predictive value for the presence of rejection by biopsy. So what does this mean? This means that if you do this blood test and your result is below threshold, you are not likely to have rejection, and you don't have to do a biopsy. And this was studied beyond the first 2 months post-transplant because a number of the genes in the algorithm are sensitive to steroids, and in the first 2 months, high doses of steroids are used, so that can affect the results. The other interesting thing we found was that, which was kind of chilling, was that there was a lot of disagreement about the diagnosis of 2R rejection. So the point where we need to treat, there was a lot of disagreement. We had local pathologists, all very experienced. Then we had a central pathology core, and they overread the biopsies. And here's an example of a local pathologist reading this as rejection. But the central core read this as something called Quilty B, which is a benign subendocardial lymphocytic infiltration named after the patient at Stanford in whom this was identified. And then a second study, Cargo 2, mainly in Europe, looked at the same thing. And they found the same thing, that in 2/3 of biopsies greater than 2R, there was disagreement between the central panel and the local pathologist. So what this means is that endomyocardial biopsy is highly subjective. We knew that, but that we've also been overtreating patients for decades for rejections that aren't there. So the goal should be to identify other approaches to detect, to diagnose rejection. So this is where we've been. The initial ways of detecting rejection were clinical. Patients would come in with heart failure, and they'd be critically ill and often couldn't be saved. Then with biopsy, histologic diagnosis was made, so rejection was made even earlier. And now we're in the molecular period where we can detect it even earlier. And I'll skip these slides. The positive predictive value of this test is 5.6%. So just because you're above threshold doesn't mean that you're going to have a rejection. We were among the first to use this at Hahnemann clinically. And if patients had an elevated score on the AlloMap test, we do a biopsy. If they didn't, we wouldn't do a biopsy. There was a randomized trial published in the New England Journal of Medicine 11 years ago, led by Mike Pham at Stanford, looking at management of patients with gene expression profiling or the AlloMap versus standard approach with biopsy. They randomized 600 patients. It was event-driven, and patients were randomized to GEP or biopsy. These were the primary endpoints and secondary endpoints. And so patients who had scores under 34 did not get biopsies. Patients who had scores above 34 did get biopsy. And one of the criticisms, which I think was appropriate, was that only 15% of these patients were in the first 6 to 12 months post-transplant. And that's when rejection is most likely to occur. And there were no patients within the first 6 months, which is when rejection is most likely to occur. But I think people were nervous about using it then. There was no difference in survival, no difference in primary endpoint. So gene expression profiling about the first 6 months post-transplant is a reasonable approach for managing these patients. But what do we do? And the other thing is that there were fewer biopsies in patients in the gene expression profiling group than in the biopsy group, not surprising. And patients were happier when they weren't getting biopsies. Well, that's not a surprise either. So what do we do within the first 6 months when patients are most likely to develop rejection? I'll talk about that in a second. There was an interesting observation out of the image study where there was a group identified with chronically low scores, and they were compared to patients who had scores under the threshold for rejection, but were higher than this group with the chronically low scores. And patients with chronically low scores had far fewer treated rejections, far fewer adverse events, and they were on less steroids. And so this suggests that there are patients who are immunoprivileged post-transplant who can be more aggressively weaned in terms of immunosuppression, and that this test can identify these patients. And you see less steroid use. So there was another study, the E-image study, which is early image study, where patients were studied from month 2 to month 6 post-transplant, where rejection is most likely to occur. The endpoints were the same as the image study. There was also an IVUS endpoint. This was a single center study from Cedars-Sinai. And they had 30 patients in each arm. And these are the clinical events. They also looked at steroid weaning and found that there was no difference in terms of clinical events, shown here. No difference in terms of events here. And obviously many more biopsies in the biopsy group than in the gene expression profiling group. And the positive predictive value was low. The negative predictive value for rejection was very high. They were able to successfully wean steroids in patients receiving, being managed by the blood test as opposed to the biopsy. This shows weaning of prednisone. And no difference in cardiac allograft vasculopathy defined by intravascular ultrasound. So what this shows is that you can start from month 2 post-transplant and beyond and manage these patients using gene expression profiling as opposed to biopsy, and using it as a screen for determining who needs to be biopsied. And this has resulted over the past 10 years in a shift to using gene expression profiling and reducing the number of biopsies. And this just shows weaning of immunosuppression. The group in Scottsdale, Mayo Scottsdale, showed that they could wean steroids using gene expression profiling guidance. And as a result of this, this research, the gene expression profiling test, the AlloMap, was class 2A indication with level of evidence B. It's now level of evidence A because there's several clinical trials. And that's pretty good for the heart transplant guidelines. Now, there's another test I just want to talk about very briefly to wrap up, because it's taking the transplant world by storm, not just heart, but kidney and lung. And this is looking at cell-free DNA derived from the allograft. And this is a marker of allograft injury and can be quantified. This is the basal amount produced in transplants. But if there's something that causes injury, which can be rejection or transplant coronary disease, that results in an increase in donor-derived cell-free DNA. So this is how it's done. There's a low basal rate, but with rejection, there's damage to the allograft and release of donor DNA, which can be identified in the blood. And it's a marker of injury. This is from an early study at Stanford showing that when patients had 3A or 2R rejections, the percentage of donor DNA spiked and with treatment was reduced, and can even predict rejection. So before rejections, this can increase. So you can identify people who may develop rejection. And this is a study from Medical College of Wisconsin, which suggested that in small number of patients, a patient with vasculopathy can have elevated donor-derived cell-free DNA. This has been looked at more extensively now. And so here's a 2R rejection. Here's antibody-mediated rejection. So there's another form of rejection caused by antibodies, which is not picked up by the gene expression profiling test, but can be picked up by this test because this is a test of allograft injury. And so where are we with this? There's a big registry where a number of transplant centers around the country obtained samples of donor-derived cell-free DNA and looked at this compared to outcomes, to biopsies, development of transplant coronary disease, echocardiography. And the thought would be to compare this and see if donor-derived cell-free DNA can predict adverse outcomes, including cardiac allograft vasculopathy, and identify people who need angiography and perhaps switch to the mTOR inhibitors to mitigate progression of cardiac allograft vasculopathy. And the degree of donor-derived cell-free DNA is correlated with the severity of rejection. And so a lot of centers are now using this this can be done within the first month post-transplant. They're using this to reduce the number of biopsies and only biopsy people who have elevations in donor-derived cell-free DNA. So where do we stand? I think this is a promising technique. It's a rule-in test. The gene expression profiling test is a rule-out test, but it may be helpful in helping us detect cardiac allograft vasculopathy, in detecting antibody-mediated rejection, and may be helpful in weaning immunosuppression and adjusting immunosuppression. And we're still waiting for further studies of this. It does correlate with biopsy-proven rejection, shown here from the Stanford group, and correlates with treated rejection and increases the month before rejection, as I showed. So this is what we think happens. As a result of injury to the allograft, the percentage of donor-derived cell-free DNA increases. With treatment, it decreases. And that shows decrease after treatment. And we'll have to wait for more studies. This is not organ specific, so it's also being used in kidney transplants and lung transplants, and can't really distinguish if there's rejection, which organ there's rejection in patients with multi-organ transplants. So we don't really use it in heart kidneys or heart lungs. But it is a very promising diagnostic technique. And this is the SHORE study. This is the registry that I mentioned to look at the association of donor-derived cell-free DNA with cellular rejection, antibody-mediated rejection, and cardiac allograft vasculopathy. There is, in addition, other novel biomarkers, microRNAs and exosomes, which are being evaluated. And there's also some work from Phil Halloran's group looking at changes in gene expression in the endomyocardial biopsies, predictions of bad outcomes. And we don't exactly know where that fits in terms of therapy, but there's a lot of exciting things going on in terms of transplant diagnostics. So this, again, I showed that vasculopathy is less likely to greater freedom from vasculopathy because of statins, less renal dysfunction, less malignancy. So we're doing a better job. One other thing that is being done is using donors after cardiovascular death. If you remember, the very first heart transplant that was done was a DCD heart. And so what happens is the donor is removed from the ventilator and the heart's allowed to stop and then rapidly harvested. And this was pioneered more recently in Australia and in the United Kingdom. And it's put on this transmedics device to perfuse it ex vivo. In the UK, the number of transplants declined precipitously, number of donors declined precipitously. This shows the UK waiting list, but DCD donors essentially saved transplantation in the UK. And the number of transplants almost doubled. DCD transplants are more expensive because the heart may only slowly recover post-transplant. In Australia, because of the distance between transplant centers and donor centers, they've pioneered this as well. They've shown excellent outcomes. Another thing that we and others have done is to use hepatitis C positive organs. So we can send patients to take hepatitis C positive organs. And the reason why that is successful is, although virtually every patient who gets hep C positive organ gets hep C, the virus can be eradicated. Also, the opioid epidemic has had one salutary benefit, which is that there are a lot of young donors now, and the data are that those donors can be used very successfully. And then finally, xenotransplantation, which has been called the future of transplant and always will be, may in the next few years ultimately make it to the clinical arena. And the reason is that using CRISPR-Cas9 technology to edit in pig hearts, edit the swine lymphocytic antigens, which are targets of the immune system, and the porcine endothelial retrovirus genes, which could cause a lot of havoc in humans. These porcine transplants can be gene edited to make them safer for humans. And the thought is that in the next 2 years, we'll see the first porcine kidney to human transplant, and then heart may follow that. So this is me at the symposium. What have we learned? Basic science and immunology is important. Always listen to your transplant coordinators. Many challenges are left, but we are making progress. Too much immunosuppression is not a good thing. And be prepared to be surprised, as with the CTOD11 study of rituximab, which I showed you. So thank you very much for your attention and for your invitation, and I'd be happy to take questions. I think there are some in the chat box. Let's see.
So, Dr. Eisen, that's an excellent summary of actually true journey of heart transplant from xenotransplant to DCDs and future xenotransplant. I think there are some housekeeping items in the chat box. Please leave any questions in the chat box. I do have a question. What are your thoughts on Tic-Tac? Can you provide commentary on Tic-Tac clinical
Yes,
trial?
Tic-Tac was a study done by Dave Barron when he was at Newark Beth Israel, looking at monotherapy with tacrolimus. I think it's it's an interesting thing, and I think certainly beyond the first 6 months post-transplant, using tacrolimus alone can be done. I think a lot of us have not been as brave as David to do that, but it certainly is something that could be done. There's another point made by Dr. Cohen that picture was Sophia Loren and not Gina Lollobrigida. So the error is at the Heart Transplant Museum in Cape Town, South Africa, because I took the picture there and identified the woman with Christian Barnard as Gina Lollobrigida. And then Jorge P. said, any comments on management of tacrolimus when amiodarone is initiated for the management of arrhythmias? You actually don't see a lot of interactions between tacrolimus and amiodarone, but the problem with amiodarone used pre-transplant is it's associated with primary graft dysfunction, which is where you take a perfectly acceptable donor heart, you transplant it, and then the heart really fails to perform adequately within the first few hours or when you come off bypass. So it requires an assist device. So a lot of us have been trying to get our patients off of amiodarone. We have one person waiting right now who's had a lot of VT, and we're managing him with mixilotine as best we can, but that's the major concern with amiodarone. Any other questions?
Any other questions? I do have one more question. So the approach to induction has changed over the years.
Yes.
So what is your strategy and what do you do at your center?
So what Dr. Mungal is asking is the use of antibodies in the early post-transplant period to allow the delay of calcineurin inhibitors, which are nephrotoxic, especially early on. And when I was at Temple and at Drexel, we would use only antithymocyte globulin and only use it either in sensitized patients, people with antibodies, potentially have antibodies against the donor heart, and also patients who would elevated creatinines, just to try to prevent nephrotoxicity. But at our present center, the tradition has been to use basiliximab, which is an anti-IL-2 drug, which I'm not convinced really works all that well. But we use ATG mainly for people who are sensitized or have elevated creatinines going into transplant, so we can delay as long as possible the initiation of calcineurin inhibitors. That's what we're doing.
Any questions? Okay, Dr. Eisen, it's a pleasure and a privilege to listen to you. And thank you for coming and giving us this wonderful lecture. I hope to get you here in person at some point of time.
Love to do it. Love to do it. I hear the weather's nice down there.
Yes, way better than Northeast, that I can tell you.
Well, thank you very much for having me, even virtually. And everybody stay well.